So far in Birmingham, we've heard a series of messages. We've heard there's loads of different variances. We've heard that we're probably a victim of our own success. We're being advised to think very differently about how we work and that we may be looking in some of the wrong places. We need to look internally. We don't have much data. We have no agreed standards. And we know about the importance of the partnerships between people with MS and the teams who are trying their best to look after them. And we need to marshal the political argument. So what about audit and quality improvement initiatives? Well, they work conceptually and empirically. Conceptually, you look at your practice, you identify your strengths and weaknesses, you celebrate your strengths, you address your weaknesses, and you have shared benchmarks to formalize care standards. Conceptually, it's a very straightforward process. Empirically, there's plenty of evidence around for the value of audit programs. The stroke audit program, the National Surgical Quality Improvement Program, they've not only identified ways of developing and improving care, but they form networks and partnerships that are so integral to success. So what do we have in MS? We've already seen. We've got loads of initiatives. We've got guidelines and position papers, but we have no comprehensive care standards addressing how to maintain people's brain health. Now, this has already been shown a few times. I think it's a really important document. I guess I've got a slight conflict of interest there, but we try and encourage all our people with MS to read this, and we get lots of good feedback, and I think we've heard some good feedback of it over the last couple of days. It's highly endorsed. There is one missing name of this group, which is the Association of British Neurologists. And the reason they don't endorse this is they won't support anything that has any pharmaceutical background to it. But the issue, of course, is how do you take a report like this that you believe addresses important issues, that of time, and how do you turn it into something that gives it a real life rather than a piece of paper, a document to circulate. And so the next step of this was to take it and turn it into a set of quality standards based around timings. And that was the piece that we have just completed and is actually is available for download from the MSJ website as of Wednesday. So how did we do that? We took a Delphi process of neurologists representing 19 different countries where MS has a high incidence. And we got them to produce recommended timings for aspects of the MS care pathway. And they're all in the paper, so you can go and pick them up. They've been set in 3 different levels. A core standard, which is considered the baseline, the standard that we should all be able to deliver on. An achievable standard, which is a good standard of care, and an aspirational standard, which is a high quality of care. So those standards now exist in the public domain for MS based on the principles identified in Time Matters. And that's the publication for you all. You can get that. Now the next step is to turn it into some sort of instrument that can be used, a quality improvement tool against which we can benchmark and use in practice to provide us with the data about our services. And so at this stage, the first job was to turn it into a simple spreadsheet tool, an Excel spreadsheet that can be used to put data in, have a look at some data and get a feel for how this may be developed. And so there was a very small pilot study done in 3 areas of the world, with us in Plymouth, in Germany, at Dresden, and in Melbourne, just small numbers of patients to gain data and to give us a feedback of the information, to give us some baseline ideas. This is some really simple top-line data from the very early pilot stage from Plymouth, just to show essentially most of the standards were met. 20% of the time we didn't. and there was a lot of missing data, and there are many reasons for that. So what does that tell us? That we have limited documentation, that we need to address the documentation issues, and we can do that through templates and ways of collecting data. It highlighted the benefits of electronic data records, and it also highlighted the key roles of the multidisciplinary team in patient care, and specifically the MS nurses and the admin team. There's also being developed a patient-based tool for them to feed back on their service experience, and that again forms part of the holistic quality improvement process. Now, the next step, which I guess, and I've changed this based on the last day, is how we use this in a powerful way. And to do that, it obviously has to be a user-friendly tool that integrates into clinical practice and facilitates clinical practice. And actually, essentially, we've heard the terms bandied around in the last couple of hours about clinical management tools. And I prefer that term to a database or a registry, because actually if you have a clinical management tool, it informs and aids and guides your clinical practice. Now, there are those forms around. IMED is one of them, MS Base is a second, and the optimised study, which Ruth talked about and is due to start in its pilot form soon, is a third. But just to give you an idea, this is a person from our IMED database. What you see there is a lot of vertical red lines. Those are her contacts with the MS service. The blue diamonds are her MRI scans. The blue rectangles are various important key blood monitoring tests, but not her alemtuzumab monitoring tests, which are independent of that. And at the bottom, you see her EDSS. And with this, you can guide someone's management in a much more effective way than working through a set of notes. And we have found IMED to be very helpful to us, and I've no doubt that this is exactly the sort of information that will be provided by optimised, and it's the sort of thing we need the quality improvement tool to fit into in a way that the information is not having to be retrospectively collected on a set of people every year, but it's a rolling, growing, developing process. And that's, I guess, the bit that I picked up from Ben Bridgewater's talk yesterday afternoon, was the second part here is how we use some of the digital thinking to plan tomorrow's service rather than just to fit into today's service. Now, I don't have the solutions for that, but I was very taken by this argument and these issues that we have to think and change the way we practice for the future. If we can get the slides to move. So, in summary, audit and quality improvement tools enable an analysis of variance because they provide you with the information of how your service is. They enable us to identify the strengths and weaknesses from which we can then examine why it is we underperform, as it were, and it gives us the benchmarks and the information to develop services. These tools are coming. They're going to be highly valuable. We've already heard multiple times from people about the importance of national audit data, and these are going to be one mechanism by which they can be provided. But they're much more important than that, in that they facilitate practice, they help us to advance care. Whether they will change variance or not, I guess a number of people have raised that variance may not change, but the quality of care will go up, and they can be used to drive policy changes. But I guess one of the key things about quality improvement tools is to not be scared by them. They're there to help us. They will identify limitations, there's no doubt. And we've all recognized that there are limitations in the services that we have and against what we would really like to be able to deliver. But they're not to be feared, they're to be embraced and used in a very positive way. So I'm done.
Thank you. Questions? Comments? Just to reiterate what I said earlier, we're almost certainly going to be forced to do this by NHS England. They're not going to want a 30-item one. I think Jackie Kemp said to us she was expecting a quality improvement tool or a national audit to have about 5 to 8 metrics, something simple. But the metrics will have to cover and that's going to be, we as a group could inform and at least when this download this, which ones should be in the national audit to cover the whole pathway, and not just disease-modifying treatments, obviously. Okay. So that's why, if you're interested in data and audit, go to the data breakout session if you want to make it. Any questions? Nobody. Does anybody disagree with having a quality improvement tool, or here's one at the back? Are you going to disagree?
So, I mean, I think Neil's talk alluded to the fact that most of these databases and quality improvement tools are sustainable in the long run. So they will kind of run themselves because they would lead us to point out that the fact that the patients are coming in an acute setting, we're picking up relapses more and treating them more would mean that they have less hospital admissions. But obviously these databases and these tools require an upfront cost. They require sort of a financial kind of backing. And a lot of us who are trying to set up these databases in our trust struggle with trying to convince our trust to actually back us up on this, because there's no cost effectiveness data available out there, which actually gives us sort of, robust backing in terms of the, what we're just discussing. So my question is whether we can sort of, first of all, as a community, whether we can actually agree on sort of, coming up with a solution to the problem which each one of us is facing in our individual trusts, and whether you've got any ideas towards that. So
I guess if Ruth is still here, she might want to talk about the longer-term plans for optimised, but she's not here. So I guess that the optimised study, which is a very much more swanky version of the type of thing that IMED is probably the future for many of the data collection mechanisms in the UK. But if you wanted to get going, IMED's free of charge, and I'm sure that you will get sponsorship to help you use it. Now, what we did, we got drug company money to employ somebody to put the data in the first instance, because once the data are in, once you've got your base information in, so a list of people, etc., and you can then start to work as a team to use it, and you then have to change the culture of people so that they actively use this in their daily clinical practice. And what you do find, and there is an investment, there's a bit of personal investment, but if you want to deliver better care and actually want to speed up parts of your care process, then these are very valuable to do that. You have to be willing to.
So the good thing about the optimised, it's a study, and it's been adopted by the NIHR and the network. So you will be able to apply for, if you belong to the optimised study, you'll be able to use a network resource, nursing or administration time to run it.
Yeah, I was just wondering whether the software that's created to handle the data, not necessarily the databases themselves, whether there's been any thought to producing material that's open source rather than proprietary or licensed, because one of the big problems about using even IMED is, okay, even if it's free, it's the company that controls it.
Yep, it's a problem. I think Optimize overcomes that.
Yes, yeah, so Optimize is an open source, and all the code's available. And it's actually, the terrible thing is it's on a database platform that is EU funded. It's a part of an EU, one of the big data initiatives funded by the European Union, and I just hate to know what's going to happen to that link post-Brexit. But anyway, in the spirit of us staying in the European Union and being part of the European Union, I think that we will probably be able to continue using that data standard, which is essential.
I have a maybe naive question. We're discussing many years about data collection, etc., and a lot of issues. Who is going to put the database? I just would like to ask you, what's your personal experience, because you travel to other countries and you've seen other registers. For example, in Denmark, Sweden, who are putting the data in database after seeing the patient? Because they have robust database.
So I guess in the Swedish data, which is essentially IMED based, then my understanding is the clinicians put in the information at the time, and that's what we do when we see people.
Yeah,
They
so
don't, do they?
it is a clinical management tool,
Yeah.
and they use that to manage their patients.
Yeah.
The good thing about Optimised, it's going to be designed with a little button. So if you're using an electronic patient record like we use Cerner, it's going to be able to transfer that information directly into the Cerner database without having to reproduce the double entry. So those little patches, as was alluded to, are going to have to be set up at each trust. But if it's working for the main electronic patient records, putting the patch in at each NHS hospital shouldn't be too much problem. But it's going to allow the data to be at least transported into your electronic patient. That's the idea of it.
I mean, for these things to be beneficial, they have to be prospectively living and developed and become part of your clinical practice. They have to facilitate what we do on a day-by-day basis. And having somebody's MS profile on one page since she presented in 2013 is unbelievably helpful. And all those red lines were contacts with the MS service. She's very labour intensive.